Okay, so I'm going to talk about bidirectional learning in global orthopedics and, not just missed opportunities, but where can we go from here? These are my disclosures. So in terms of outline, I'm going to sort of touch on three themes. One is, what can the North American orthopedic surgeon learn from their peers in the low and middle income countries? And then a little bit about this visiting scholar program where, peers, mostly practicing orthopedic surgeons, come from a low middle income country and spend a short visitation of a few days to a few weeks in a North American center. And I think while there's been some talk and literature on how this has impacted the North Americans, there's very little insight into asking the visitors what they feel about this experience. So we'll touch a little bit on that. And then finally, a few words on what we feel are the barriers and potential solutions to bidirectional learning. And I think that'll be expanded more towards the end of the day, where we'll have a nice open session on discussing this further. So I'll just start with, a little vulnerability on my part. So I did this teaching / medical mission in Southeast Asia in 2009, where I was invited for 2 weeks to sort of help the local surgeons with pediatric orthopedic learning. So I landed late in the evening, early the next day with a jet lag. This was presented to me, a 16-year-old female with cubitus varus post-traumatic, very common malunion of the supracondylar humerus fracture. And along with the local surgeons, we drew lines, planned the osteotomy, performed the osteotomy nicely, good result. And I left because they had graciously invited me to go on a city tour. So I just went on a local sightseeing. And the next day when I came back, I saw that this patient had, clinical signs of severe compartment syndrome. The arm was swollen, blistered, etc. I felt terrible. And thankfully, we were able to do a forearm fasciotomy. The muscle was viable. And I think the limb was salvaged. But that was quite a hurtful moment and literally very embarrassing for me, starting this 2-week trip with this as my first case. So I think, if you dissect back, you say, well, what happened? So I think false assumptions were made, I feel, on both sides. I thought that the local surgeons see these kinds of patients all the time. They'll do the appropriate splint, casting, etc., a post-op check that I was used to, in my home program. And the local host probably thought that let's not disturb this visiting surgeon who professes he's an expert and not disturb him during his city tour out of respect and hospitality. And then, certainly I was blindsided because next day I went and I looked at their OR list. And as you can see on that right side, the same surgeons were also doing a thyroidectomy, a cleft palate, a burn resection, et cetera, and, smattered in there were a few orthopedic cases. So I just failed to recognize the local environment that I sort of thrust myself in. So I think for the rest of the trip, it was very humbling. I tried to listen, learn, and assist and, share my experiences and obviously learn from the locals. So I think this is something that's been, said time and time again by a lot of the leaders in the field of global orthopedics and global surgery, that when you go visit or share experiences, you want to leave skills and knowledge and not scars, both literally and figuratively. So we know there's a big north-south divide, not just, and like Dr. Coughlin just mentioned, not just socioeconomically, but healthcare disparities in terms of what's available, the ratio of surgeons to population, the global burden of disease for road traffic accidents, et cetera. And certainly the old model that's rooted in medical colonialism, knowingly or unknowingly, which is a one-way street of the high-income country quote unquote giving to the low and middle income country peers. So the paradigm has certainly changed. The world's become flatter. This whole concept of give and take, where givers are winning, has become more popular and understood and recognized. So getting to the meat of it, what can the high-income countries, surgeons and trainees learn from our counterparts in the lower and middle-income countries? And these are the few things that come to mind. Creative solutions to complex problems, at a low cost, utilizing resources that are locally available. This concept of focus factories, where a center or a bunch of surgeons do kind of a theme-based surgery, take care of patients of all socioeconomic strata, and they get good at it with great outcomes and low cost. The natural history of certain diseases, which we end up not seeing in North America and other high-income countries because they're treated and picked up early. What about management of resurgent problems such as polio and polio-like conditions? And then really this concept and this hunger and reverence for knowledge, which I feel you can't quite capture, but you know it when you see it, that if it's a trainee or a peer who's really wanting to learn and know something, the whole interaction with the trainer-trainee is definitely more enriched. So I want to talk about this concept of reverse innovation, where it's what's called a trickle-up effect, meaning there's some technology or innovation that's actually devised or innovated in a resource-limited environment, and then through this roadmap of innovators, early adopters, knowledge brokers, gets transferred to a high-income country and then kind of takes off with a tipping point. And there's been some research done both in the healthcare and in the business field on this concept of reverse innovation. So I think for us, this is a limb deformity webinar. So I think, Ilizarov would be a great example of reverse innovation. This whole concept of distraction osteogenesis really started in Siberia, where Ilizarov, who was not even an orthopedic surgeon, he was a family doctor. He was stuck with a lot of patients post-World War II with limb deformities, limb defects, non-unions. And he creatively and innovatively sort of came up with this methodology of gradual correction and bone formation. So, and if you go back to how this came about and how it took off and spread across the world, it was actually Thor Heyerdahl, who was a Norwegian anthropologist, and he was a big proponent of inclusivity. And so he tried to capture a trip from a segment of the journey of Christopher Columbus, and using a raft with people with different backgrounds and ethnicities. He took a sailing trip from Morocco to Barbados. And in that crew was a Russian doctor whose name was Yuri Senkovich, and Carlo Mauri, who was an Italian photojournalist. Now, it turns out that Carlo had a tibial non-union that had been treated in Italy by multiple experts, but he still was symptomatic and had an ununited tibia. So Yuri Senkovich tells Carlo about Ilizarov and encourages him to visit Kurgan. And here you can see Ilizarov with Carlo, and here they are enjoying a smoke, which is unheard of in this day and age, right as he's waking up. So anyway, this was a success story. Carlo has a united tibia in a few months, and Carlo, being from Lecco, Italy, is friends with Angelo Villa, who is part of the orthopedic inner circle. And Angelo tells this sort of success story to Dr. Cattaneo, who at that time was the president of AO Italy. And then just the word spread, and the Italians invite Ilizarov to come down there. And then sort of the tipping point, I guess, for the North Americans was the Richards Medical, who was an organization that preceded Smith and Nephew, takes a bunch of American doctors and Canadian doctors to Kurgan to visit Elizarov in 1988. And I think from there on, it sort of took off. And then a lot of the North American surgeons then creatively innovated further. So, in the past 25 years, I can see how this has impacted in my practice, going from standard Elizarov to the hexapod with computer generation to then internal lengthening nails, and now sort of a combination of external internal lengthening. So what about this concept of jugaad? Now, jugaad is actually a term that some of you may not be familiar with. It was an Indian colloquial word that's now in the Oxford Dictionary. And it's really a combination of being frugal, flexible, and inclusive, using, using local resources in a very creative and a non-linear thinking way. And so there's many examples, of course, of how people do that. But if you look at orthopedics, and it doesn't have to come from a low middle income country. Like the top left one was an article from, I think, a naval center in the US, where they're trying to use an arm board as a spica table, and Matthew Voorhees, who's going to be speaking later, I visited him a few times, and I was impressed with how you can use a spatial frame strut to do gradual correction for flexion deformity of the knee. Dual rush rods for OI as opposed to the more fancy, growing rods. Scott Nelson and others have used, sterile covers for locally available cordless drills. And of course, these, less expensive guided growth plates that can have a huge impact on limb deformity correction. And the same concept also applies to orthotics and prosthetics. So the Satch foot, or the Jaipur foot rather, is a great example, which was based on the Satch foot, which is solid ankle cushion heel for below knee amputees. And this was devised actually not too far from here in Berkeley, US, but it was based more on sort of the cosmopolitan below knee amputee that uses these prostheses in an environment where people wear shoes and are walking on a level surface. So Dr. Sethi, who was an orthopedic surgeon in Jaipur, actually tweaked that a little bit in the midfoot, and the keel from being a hard surface became a soft rubber material, and it was low expense, was very rugged, and could be used, without a shoe. So it was more seamless in the community, and obviously was low cost and using locally available materials. So I think that's another example of a frugal innovation that's based on something that's tweaked from a high-income country. Resource utilization, there's so many examples of this that we can look at, and I'm not suggesting that we all go down to this, but at least we can think about it in this, world of rising healthcare costs. We use cast padding, the operating tables, solar-powered autoclaved, et cetera. And Scott Nelson shared the slide with me, which was really interesting in terms of a South-South partnership, where Scott, who's in Haiti and wanted less expensive implants for obvious reasons, took an overnight flight to India to buy locally made implants, and just turned around and brought a suitcase full of these implants to be used in Haiti. And we just have to reflect on, is it really worth using these implants just as one-time things like tourniquet, et cetera? I think they can be certainly recycled and reused. And then this, we talk a lot about value-based care, but it goes down to, giving good value and good outcome for a lower cost. And the sign nail, I think, is a great example of that, which is an intramedullary nail that is used to fix long bone fractures, mainly of the lower extremities, without the use of fluoroscopy, but with great results. So this concept of focus factories and social entrepreneurship. I think this concept, again, one example is from our ophthalmic surgeons, rather. This one in India, the Arvind Eye Institute, where their concept is they'll take all comers. Everything is very sort of segmented in terms of care, where the orthopedic, the eye surgeon will pretty much just do the surgical part, and the triage and the turnover is very efficient. So here you're taking the best of education and training and learning and experience that comes with high volume surgery. So you're improving outcomes and lowering cost at the same time, and also taking care of the entire segment of population and not just the high end of the society. And that concept of fortune at the bottom of the pyramid, which is also called social entrepreneurship, is something that's very relevant and prevalent actually in the business world. How about for our trainees to learn about natural history and creative solutions? We thankfully treat a lot of septic joints in children with early intervention, but what if you don't? So this, I think, is a great learning opportunity for our trainees to sort of visit other centers and see what can happen if these entities are not treated early enough. Different diseases with different treatment options. Again, it just opens the mind, and then once in a while you're going to have an aha moment, and you'll be able to use something that you learned in another facility in your own practice. So moving on to bidirectional learning, I just want to talk a little bit about my good fortune to accompany my mentor, Hugh Watts, and his wife, Sharon, who was a physical therapist. And unfortunately, there was a polio epidemic in Tajikistan, which is a part of the Soviet Union. And then after it sort of separated and became its own country, there was a lot of turmoil, political and otherwise. And kids weren't getting vaccinated for polio. And sure enough, there was a polio epidemic there. And Hugh, who was invited through WHO to go there to help out, since he had some experience with polio from his past experience, invited me to accompany him back in 2014. And I certainly had very little knowledge about polio. So between Hugh's teaching to the local surgeons and me brushing up with books, it was honestly a great experience to understand a little bit about polio, which in some ways contributed to orthopedics being a specialty of its own. So fast forward a couple of years, we organized a follow-up course through a collaboration with WHO and Red Cross. And knowing Matthew Verghese from before and understanding his experience with polio survivors in Delhi, so Matthew and another physical therapist from Mumbai and some orthotists from Scandinavia helped us organize a course in Tajikistan. And this just is an example of going full circle. So of course, like Rick mentioned, there's global help. So this all culminated in a book that's freely accessible now called Clinical Management of Poliomyelitis, with the help of my current partner, Colleen Sabatini. We had a course at the Pediatric Orthopedic Society of North America where this was brought up. And ironically, this polio-like issue has resurged in North America with these enteroviruses that have really come back. So it's really gone full circle in terms of polio and polio-like problems. It just sort of shows the relevance and the interconnectivity in terms of how we learn from each other. And finally, I'm going to talk a little bit about this visitorship program of clinical observership. And thanks to Kay Wilkins, who's a pediatric orthopedic surgeon from San Antonio. And way back in 2007, he very creatively donated his million American airline miles and Hilton Honors points to invite through POSNA, the Pediatric Orthopedic Society of North America, scholars from other parts of the world to visit centers in North America for typically 2 weeks. So we followed up on this sort of visitation that had been going on for multiple years and surveyed pediatric orthopedic observers who came from other parts of the world to visit North America. And we've had a few publications on that, and I'll just give you the gist that when we surveyed these 181 surgeons who'd come from 56 different countries around the world, seemed like most of them admitted to gaining new knowledge and skills that they took back and improved local patient care. And and then there was sort of this domino effect where 99% of them said they shared this new knowledge skills with their peers and trainees back home, which of course had an exponential effect on local care. And there was this whole issue and concern about brain drain, which didn't really happen, and essentially all of them returned back to their countries. Some actually went to a different part of the world to practice. And then we sort of did a follow-up study looking at what were the barriers that the visiting surgeons identified, and also asked their North American host. And again, like Rick mentioned, money seems to be the biggest problem. And for the visiting surgeons, there was this issue of not being able to scrub in the operating room. And we've sort of duplicated the study looking at trauma surgeons who visited the US, and it's that same theme. It's very frustrating for visiting surgeons because of local restrictions administratively and statewide that they cannot glove up and at least be a part of the operating room experience and just sort of be a silent observer on the side. And unfortunately, when we surveyed these visitors, nearly half of them said that nobody asked them for any feedback in terms of what they thought could have been improved. So we then recently did a follow-up qualitative study asking them more about what were their motivations, what was their relevance. And just for the sake of time, I'm just going to highlight two very interesting things which I wasn't thinking of. We asked these surgeons, like, would you prefer to come to a North American country if this was to happen again, or would you rather come or go to another country which has limited resources to learn more in terms of the relevance of what they see and do? And essentially all of them said they'd rather come to a North American center. And the reason behind that was more about aspiration and seeing what else was available. So that was a little bit of a surprise to me, but I think we can take that up more in the discussion session. And the other part, which was brought up consistently, was they felt a little left out, that nobody really asked them to share their experiences when they visited a North American host. And it was, again, going back to this theme of being unidirectional as opposed to bidirectional. And I think our next segment is going to talk more about learning from our peers in other parts. So, we came up with, a few different things that can help enhance this observership experience for visiting surgeons. And then, finally, just a taste of what I feel could be some of the barriers to bidirectional exchange. I think one is simply just the lack of awareness, interest, time, and funding. And then the other is this cognitive bias that I'm sure I have. And I think if we all deeply reflect on our own interactions, there is a little bit of that, and I think a lot of us. And then this regulatory constraints that is there only in North America and not in the rest of the world. where a very qualified surgeon from another part of the world can actually participate as an observer, as a scrubbed observer in the operating room. And I think this is a huge barrier to sort of good knowledge exchange. Now, perhaps with all the other technology that's available for remote learning, that can be minimized, and again, as a topic for discussion. And then finally, I think there's this issue of founder syndrome, or establishing silos or fiefdoms within our own partners in a low and middle income country. And I think, just like Rick mentioned, I think those need to be identified and then hopefully broken down strategically. So how do we get there? Once again, we got to decolonize these global programs and have to build academic partnerships on trust, equity, and sustainability, rooted in cultural humility. And a lot of these efforts need to be a pull from our LMIC partners and peers, not really thrust a push from a high-income country, surgeon or an organization. And I think Scott Nelson and others have popularized this quote that when you visit or are embedded in another country, you can improvise, but don't compromise. It touched on this open access to knowledge and training that has to be focused on what's relevant in the local environment. And again, expand on e-learning platforms and identify local champions, or better still, be the local champion. Thank you so much.